Hello, everyone. My name is Satish Gadi. I'm an interventional cardiologist at Cardiovascular Institute of the South. I would like to thank Dr. Walker and the NCVH team for this incredible opportunity to do this NCVH digital education series during these very challenging times. The topic today that I'm presenting on is the peripheral case I learned the most from. Pertinent disclosures. PAD is a passion for a lot of people, certainly me. Dr. Walker's extremely passionate in this, and his passion is infectious, and that's how I really became passionate in PAD, and that's really something that I enjoy doing. So every PAD case, I like to approach it in a sort of a methodical way. What I like to do, obviously, I'm sure everybody who does PAD does this, but before the case, you obviously want to get familiar with the patient, their signs and symptoms, do some non-invasive studies, ABI, Doppler. It seems simple, it seems very intuitive, but you will be surprised, how many patients who end up with an amputation actually don't even get a ABI or an arterial Doppler done. I see this even today, and it's a little disturbing, but it's the unfortunate reality. Apart from ABI and Dopplers, you may also want to do CTA or an MRA where applicable if you want to dig deeper into their anatomy. And during the case, you obviously want to have a plan A, B, C, maybe even a plan D. Um, know when to give up. Don't keep on persistent with the plan if that is not getting you anywhere. And after the case, I always like to take time and debrief with my staff. And I also make sure I have some sort of follow-up imaging. I routinely do ABI and arterial Dopplers within 1 month of the intervention to the extremity that I have performed the intervention on. And all of these things are helpful to sort of learn from the case and just get better and better at it. During the case, again, a few more important points. You always want to image adequately. You want to have a good image. So if you're doing just regular ionic contrast, make sure you have a good contrast injection and have a good picture. Use carbon dioxide based contrast, carbon dioxide based angiography liberally. Even if somebody has seemingly normal kidneys, make sure you know their GFR, their creatinine clearance, their ejection fraction, diabetic or not, which all play into the risk of contrast-induced nephropathy. So use carbon dioxide liberally and do multiple orthogonal views, do oblique views to get a good picture, and then you can have your plan and intervention. Um, Again, multimodality imaging, CTA co-registration if that is available, but ultrasound, either external ultrasound, having a ultrasound tech pretty much scrub in with you and have that external ultrasound, or intravascular ultrasound. Both of these are priceless, in my opinion. OCT-based imaging is also catching up, and that is if that is something that you like, then do that. But having some imaging other than just the two-dimensional angiography really helps. I'd like to go over this particular case that I've done in the last couple of months. Um, this patient is a 55-year-old female. She's a lifelong smoker, hypertensive, with significant lifestyle limiting claudication. Could not really walk even 10 to 20 feet was pretty much her claudication distance. She could not walk from the end of the hallway to her exam room in my clinic without having to stop pretty much 3 times during that amount of distance. I have counseled her multiple times on quitting smoking, but that's why I put the attempts under quotes. Um, History is also significant for known PAD, but also previous intervention. Most of her claudication is confined to the left leg. And she told me that somebody somewhere some time ago had put in a stent to the left leg. Unfortunately, I did not have any records of that. It seems like it wasn't done in the same town. So I was a little limited in that regard in terms of the information available. ABIs were significantly lower, particularly on the left leg, and arterial Dopplers showed an occluded left SFA. So we scheduled her for an angiogram. The inflow was pretty good. As you can see, there's some lesion in the profunda, but that's not what's causing her claudication. And as you can see, the SFA was occluded in the mid-distal portion, and there's a stent in the distal SFA that is also occluded. Unfortunately, the infrapopliteal runoff is pretty poor. The distal popliteal artery seems to be patent. As you can see that it's filling right there, and this is probably the perineal artery that comes in. And so I went about trying to intervene. I just could not cross. This was a Viabahn stent. I have a better picture of the close-up view of that stent. Initially, I was not sure what kind of a stent it was, but it was very clear that it was a Viabahn stent that had occluded. Again, I did not know why she got a Viabahn, if she had some sort of a perforation there previously when somebody else was intervening. I could not cross the Viabahn adequately. I tried, I went pedal stick, ultrasound guided, went up, couldn't cross it. I was actually repeatedly going around the stent. But I just couldn't get in the stent. And again, there, oblique views were extremely helpful. It looked like I was through the stent. When you went oblique, you then realized you were actually behind the stent and around the stent, not inside. After several attempts, I just decided to give up. I did do an IVUS before I gave up. As you can see, when the IVUS is playing, that's the perineal. And as I'm pulling back on the IVUS, you can see the stent, and you can see that the IVUS catheter is outside the stent. And this is the close-up view of the Viabahn with its characteristic striations. And this is my wire going around the Viabahn, and really couldn't go through it. In just a little while, you'll see the stent. There you go. That's the stent, and my IVUS catheter is outside. So at this point, we decided to give up. We brought her back to intervene again, give another attempt. This time I tried, you know, other crossing catheters, but again, without success. So what we decided to do was, we said, you know what, we're not even sure how useful it would be to go through the Viabahn. Maybe we could keep on trying, but that was not working. So we just decided to go around, go outside the Viabahn, ballooned it, and jail the Viabahn stent and put Supera stents overlapping with really good result. But unfortunately, the Superas were reoccluded in pretty quickly within a couple of weeks. Turns out the distal runoff was not as good as we thought it was, and that was probably why they occluded. So this time we brought it back in again, and as you can see on the in this picture on my left-hand side, you can see the Superas were occluded. This seems to be the distal, the proximal cap of the occlusion, pretty much where the original occlusion was. And then the rest of the Superas were occluded. Again, one of the things that I learned was it's not easy to cross an occluded Supera stent as well. And one of the techniques that seems to be really effective in enabling good intraluminal crossing of an occluded Supera stent is just leading with a laser, leading with a turbo power 2.3 mm turbo power laser, and let the laser, stay in the lumen. And the laser is the 2.3 turbo power laser is a pretty, hefty catheter that will not readily get into any branches or subintimal space. And the laser pulsation will enable the vapor bubble and all the reactions that happen at the front end of the laser help to sort of keep it in the lumen. So I just let the laser do the work, cross the occluded stents quite easily, and was able to cross and then wire the infrapopliteal. I think I wired the perineal in this case, and ballooned. Got a decent result. Again, you see that in the second picture here from the left, that's the proximal cap, um, which still there's a sort of a thrombotic dissection or whatever is going on here. So I decided to cover that with another stent and covered the proximal area as well, and ended up with a pretty decent result. And this time paid more attention to the distal runoff, made sure the distal runoff was good. In this case, she had a good single vessel runoff that seemed to be pretty brisk with no other issues, and subsequently the superiors and the subsequent patency was maintained. So essentially, some of the lessons that I learned from this case was number one, as I said, if plan A is not working and you've given it enough shots, time to move on to a different plan. You can always live to fight another day. You don't have to, make sure everything works on day one. You can always take the patient off, long as there's no urgency, long as there's no acute limb ischemia. You can always take the patient off the table, bring them back, have a fresh mind, fresh pair of hands, and you can, sometimes work wonders that way. Number two that I learned is occluded bonds are notoriously difficult to cross. The question is, should we even, try to cross them? In this case, we just decided to jail this Viabon and place alternative, place stents to create an alternative channel. In fact, we were actually intraluminal. So I'm not even sure if the Viabon itself was intraluminal. So that's something to be considered. Third and extremely important point, ensure a good brisk distal runoff. If that is not there, then whatever you did may go to waste. The key to long-term patency is ensuring good distal flow. And the fourth point that I learned is the Topo Power laser catheter is an amazing tool to have in your toolbox. Not only can you do really good, effective atherectomy, but also laser atherectomy is pretty much the only choice if you want to do an atherectomy in an occluded stent. And also, the laser catheter is a great crossing tool. So for all those reasons, this is an amazing tool to have. So these are all the lessons that I picked up from this case, and I hope that has been useful to you all. And thank you for the opportunity. Thank you.